Welcome. I'm Dr. Barry Losasso, the Director of the Center of Excellence for Pectus Deformities in San Diego, California since 2006. I'm a general, adult, and pediatric surgeon trained by Dr. Donald Nuss. I've done over 800 Nuss procedures over the last 16 years in patients ranging from the ages of 10 to 52. I direct programs both at Rady Children's Hospital and at Sharp Memorial Hospital here in San Diego. Today, I'm here with Kate Grace, the owner and director of Evolve Physical Therapy and Advanced Wellness in San Diego. We're going to discuss the role of physical therapy and how, following the Nuss procedure, physical therapy can enhance and improve the outcomes of the surgical procedure. Kate and I will review our approach to physical therapy following the procedure and allow patients to have the information necessary to optimize their surgical outcomes. We hope this information will fill the existing void and empower patients to achieve both a more speedy and complete recovery. First, I'd like to cover some general information regarding pectus deformities and describe the Nuss procedure. There are three types of pectus deformities: excavatum, the most common, where the chest is sunken; carinatum, where the chest protrudes; and a rare mixed deformity, which includes components of both carinatum and excavatum. Pectus deformities are very common. 1 in every 350 to 450 people on the planet have this deformity. It's more common in men than in women in a ratio of 4 to 1. 70% of patients in my series have a positive family history. The defect involves the anterior cartilaginous ribs, which grow abnormally and continue to grow abnormally until the patient stops growing. The defect worsens as the patient grows. The overall anatomy of a pectus patient involves rounded shoulders, a protuberant abdomen due to the misalignment of the abdominal musculature, asymmetry of the anterior chest wall, and sunkenness if one has pectus excavatum, and posterior components of the defect can include malpositioning of the scapulae and curvature of the spine. The pathophysiology is very interesting. It affects both breathing and circulation. The misalignment of the chest wall muscles and the diaphragm cause there to be inefficient gas exchange and breathlessness for the patient, especially when the patient is exercising. In addition, the sunken chest compresses the heart and shifts it out of place. Generally, when the patient is at rest, there are no symptoms. But as the patient attempts to do more and more aerobically challenging activities, the patient becomes breathless and becomes excessively and prematurely fatigued. I'd like to describe the Nuss procedure. It's a minimally invasive surgical procedure. It's done under general anesthesia in an operating room. It involves using a telescope in the chest to visualize the deformity relative to the heart. It requires a skilled surgeon to bend the bars perfectly to conform to the dimensions of the anterior chest. It then requires forming tunnels both superficial to the skin laterally and beneath the defect and above the heart internally. The bar or bars are placed into those tunnels, flipped into place. The chest then responds immediately and is then placed into a corrected position. Once that corrected position is achieved, the bars are secured laterally by suturing the bar into the lateral chest wall. The patient usually stays in the hospital somewhere between 4 and 5 days, and the bars stay in place for 3 years. It's during this 3-year process where the force of the bar on the chest causes the abnormal cartilaginous ribs to literally reshape themselves. The chest then achieves a permanent corrected position, allowing the bar or bars to be removed under general anesthesia as an outpatient procedure 3 years later. The chest remains in that corrected position. I'm here today with Kate Grace, the owner and director of the Evolve Physical Therapy and Advanced Wellness Center in San Diego, California. Kate and I have been friends and colleagues working on surgical patients together for the last 10 years. Kate is a graduate of the Ohio State University and has been practicing in San Diego for 36 years. She does physical therapy and is an orthopedic physician assistant. She knows patients from the perspective of someone who both operates on patients and helps them to recover. She's an educator and an innovator. She's worked on countless projects that have involved furthering the techniques of physical therapy and achieving new medical products to assist in the recovery and physical therapy of patients. Today, Kate and I will present our approach to physical therapy in the setting of a patient with pectus deformity who has undergone a NUS procedure. This is our Center of Excellence protocol, which we have developed over the last 10 years. We feel that this is an important contribution which will empower patients and will assist medical professionals across the country in helping their patients to achieve an optimal surgical result. Kate, could you summarize your approach to patient care?
With these pectus patients, we see many physical challenges. Among them are postural malalignments. Because they have a sunken chest, they have chest pain, they have tight pec muscles, they have internal rotation and anterior translation of their shoulder, they have tight scapular muscles, they have shortened soft tissue around the neck, the traps and the pecs and the shoulder. They have decreased upper extremity range of motion and neck range of motion, and they have weakness in most of the core muscles, scapula, shoulder, and back, and even their legs because they're not using them. They have decreased cardiac and lung function, so they experience shortness of breath, labored breathing, poor endurance, fatigue, and the inability to participate in aerobic activity and sports, and they have impaired oxygen delivery to the very important working muscles. They also have psychosocial challenges pre-op. Because of their inability to participate with their peers physically, they're unable to participate in even group activities, and also because they might be a little bit embarrassed, they have poor body image and sometimes interpersonal difficulties. So here's the good news. Postoperatively, their postural malalignments have been corrected. They have normal chest anatomy, normal chest function. They have lengthened muscles and soft tissue. They have full shoulder and scapular range of motion, and they have complete strength of all the muscles that were weak pre-op, their core, their back, their legs, their shoulder, and their scapula. From a psychosocial standpoint, they feel really good about themselves. It's a big self-confidence boost, and they can participate fully in physical activities and sports with their peers.
Hi, today I'd like to introduce you to a patient of mine, Cormac Williams, who's a 15-year-old volleyball player who's now a year following the NUS procedure.
Hey, Dr. Losasso. How's it going?
Hi, Cormac. It's nice to see you. This is Cormac Williams, who is here today, 1 year following the NUS procedure. How time flies, huh?
Yeah. It went by really fast.
And you're doing well?
Yeah.
And your principal sport is volleyball,
Yeah,
correct?
volleyball.
And so you did your physical therapy here at Evolve with Kate and her staff. Mm-hmm. How did that go?
That went really well. They were all very helpful. They were all just really great people, and they helped me get back to my sport.
Great. So your symptoms before the surgery included shortness of breath and a lot of fatigue when you tried to do your sports. The operation is, as we said, a year ago. Mm-hmm. And have you noticed that your stamina has improved and the shortness of breath has gone away?
Yeah, I can definitely run a lot longer distances than I could and for a longer time than I could.
That's fantastic. So today, Kate and you are going to go through some of the exercises that you did early on after the surgery. I want to thank you for participating. I really appreciate it.
Thank you for having me.
We do several stretches to improve shoulder range of motion and reaching mechanics. A few that Cormac and our patients can do at home are in the doorway. So Cormac's going to stand right under the doorway. He's going to put his arm at 90 degrees behind the doorway, and he's going to lunge through and step through with one of his legs in good alignment. And this is to stretch the front of his shoulder, shoulder capsule, and the rest of the shoulder joint. They typically hold this for about 20 to 30 seconds, and they'll do these 10 repetitions several times a day. This is very early on in the first 4 weeks post-op. Another great doorway stretch to stretch the capsule of the shoulder and increase reaching mechanics is with his arm up above the door or on the side of the door with his arm straight this time, so it'll change where the stretch happens in the capsule of the shoulder, and he's going to step through again and stretch that way. Now, these should be what I call moderate stretches. They shouldn't be severe or nothing that the patient can't handle, but it shouldn't be mild either. Remember that these patients have really tight shoulders initially, so this is a big, he's great now, but this is a big opening for them initially. So we're still in the first 4 weeks. Early on, breathing, diaphragmatic breathing is really important because prior to this, patients don't want to take a deep breath or aren't able to. And then afterwards, they still don't want to take a deep breath because they're afraid they're going to hurt the bar. So how we teach patients to do that is we put our hand on their belly, and when they inhale, their belly comes all the way up into my hand. So big inhale. Now you're going to hold that there. Inhale a little further. Hold that there. And then exhale and come on down. Very important that you get each part of the inspiration. Early on, these patients use an incentive spirometer as well, many times a day. Very, very important. But when they come into physical therapy, we want to make sure that they're diaphragmatic breathing correctly. So let's do it one more time. So breathe in. See his belly's expanding. And breathe in a little bit more. Hold it. And relax. Nice job. One of the exercises we do early on is called a pelvic rock. The reason for this is because in their posture malalignments, they often change their pelvic position to make up for their sunken chest. So it's important that you take the pelvis and work it independently from the rest of the spine. So in a pelvic rock, what Cormac is going to do is he's going to push his pelvis back and flatten his back right in here so there's no space or light between his back and the table. And then he's going to rock it forward to create some space. So he's doing what we call a posterior pelvic tilt, so flatten it and rock it back. And then he's doing an anterior pelvic tilt forward. Very easy for them to do, and it feels really good because it loosens up the pelvis and it separates the pelvis from the lumbar spine. Because he's had surgery, he's going to have scar tissue where the incisions have been made. So it's important to make sure that all that soft tissue is returned to its normal flexibility. And so what we do is a little bit of soft tissue work early on to make sure that there's no scarring, which then will inhibit his function and his movement. So part of the soft tissue techniques are going in all different directions around the scar, in between the intercostal muscles of the ribs on both sides, all the way along the bar, on his pecs and his rib cage, and across to the other scar. So we spend quite a bit of time on these to make sure that this tissue should feel exactly like the rest of the tissue in his body after a certain period of time. But it's important to do this work early on so he doesn't scar down for a longer period of time. Early on in the first 4 weeks, it's really important for us to get back all their shoulder range of motion and mechanics and start addressing getting their shoulder back into a normal position. One of the most important things to do that is you must do some type of manual therapy to stretch out the shoulder joint and also the capsule, and the inferior and posterior capsule in particular, because those are the capsule areas that are going to become the tightest. So what we do is we have the patient's shoulder very close to the edge of the table. We'll distract it a little bit out away from the joint, patient's relaxing, and then we're going to mobilize the inferior capsule of the shoulder while we're distracting it. And then we're going to keep that distraction on, and we're going to mobilize the posterior capsule of the shoulder. The patient doesn't have to do anything here, and it starts stretching out the capsule and preparing it and getting ready to do the rest of the range of motion. Then early on, again in the first 4 weeks, we'll passively take the shoulder and work it through all the ranges of motion that the shoulder allows, and then we'll start active assistive so the patient can help a little bit. Most importantly, when you're doing the glenohumeral movements, that you stabilize the scapula, because what we don't want him to do is get his shoulder up into after 90 degrees and use his shoulder blade instead of his shoulder. So you'll stabilize the scapula as you work on specific glenohumeral motion. And then we'll work that in all different directions of motion early on, get all the range of motion back, then we can strengthen him in a full range of motion position. Early on in the first 4 weeks, it's very important to stimulate all the muscles around the scapula. So what we're going to do is a series of PNF patterns with the scapula, and now the patient's going to participate. So they're on their side, your hands are on the scapula stimulating the muscles that you would like to contract. So the first thing Cormac is going to do, I'm going to move his scapula toward me a little bit, and then he's going to contract the scapula and bring it down toward his spine. So relax and pull. You want to make sure that your hands are only in the position of the muscles you want to stimulate, and also that you get into a rhythm with a patient that they can do. You don't overpower them, and you also give them enough resistance where you can strengthen the muscles to support the correct position of the scapula on the spine. Then we want to make sure that we go back toward the spine and down, so I'm going to move you this way. Now pull for me down, keep going toward your spine and down, and toward your spine and down. And then we can do all kinds of different directions, clockwise, counterclockwise, but just making sure that we give him the right amount of stimulation to get his shoulder blade back and down. Typically, his shoulder blade and shoulders are rolled forward, so it's important that we stimulate the muscles and retrain them to get the scapula back toward the spine and where it's supposed to be, aligned on the thoracic spine. Now we're going to go through the NUS rehabilitation protocol. The key points to this is just a guideline. As with any post-surgical patient, each program needs to be individualized. There's no cookbook. Each patient is giving an individualized program depending on what we find in our evaluation. The post-op success of this program relies heavily on the commitment, the talent, and the creativity of the physical therapist. At 4 weeks, we're really focusing on supervised, assisted, shoulder range of motion, and postural corrections. After 4 weeks, at 6 weeks, we progress into strengthening, and that may include working in the gym with some weights, some balls, and some bands. At 12 weeks, with MD clearance, then we really work into sport-specific training, and that'll include agility, speed, jumping, landing, sport-specific, whatever it is they want to be involved in, and increasing their aerobic capacity. To help us go through the more advanced parts of the protocol, our friend Victor Valentino is with us today. Hi, Victor.
Hey, Kate. How you doing?
Thanks for coming.
Thank you.
Victor is a phenomenal personal trainer in San Diego that both myself and Dr. Losasso have worked with. Tell us a little bit about your credentials and what's really important to you as you work with a client.
Well, I've been in the fitness industry for the last 24 years as a coach, personal trainer, and Pilates instructor. And my focus on training is on posture work, corrective exercises for the posture, functional strength training, and core work.
And he's really great at it. So he's going to help us go through the exercises that are a little bit more demanding as we move this patient through their exercise protocol. One of the most important exercises we do at the 6-week mark is a resisted band shoulder external rotation. Very important rotator cuff muscle and a muscle that's responsible for helping us get the scapula in the right position. So Victor's going to take a resisted band, wrap it around his hands a few times, keep his elbows locked in really tight, keep his chest and sternum up, and he's going to pull apart so he performs external rotation at the shoulder. The muscle is actually back here. So as he contracts the muscle and pulls his shoulder blade toward his spine, his arms are going to externally rotate. We're going to start at 6 weeks increasing our resistance exercise. One of the most important exercises for this patient is external rotation of the shoulders, which stimulates the muscles in the back of the shoulder blade and responsible for strengthening the shoulder and the shoulder blade. So what Victor's going to do is he's going to take a resistant band, he's going to wrap it a few times around his hands, he's going to keep his elbows in nice and tight, and he's going to push out with his arms as he activates the muscle behind the shoulder blade and perform external rotation with him in good posture and his chest up nice and tall. We're adding a dumbbell exercise now in the scaption angle, which will incorporate the muscles of the shoulder and the shoulder blade. So Victor's going to hold a light weight in his hands, and he's going to start with one arm, and we're going to come out at a 45-degree angle just above the shoulder as he elevates his arm against the weight. One of the most important things to do here is as you elevate your shoulder, that you coach the patient on keeping the shoulder blade down. So they are using good mechanics and good posture. Once they've got that really well on both sides, we're going to add that to both sides. So we're going to do both together, which does take a lot of strength and control. He's got to fire his core muscles, keep his chest up nice and tight, and only use his shoulder, raise his shoulder, so he keeps his shoulder blade down. As we move into core strengthening, it's very important that we make sure that the vertebrae have as much flexibility as they need. So we're going to start on hands and knees, hands right under your shoulders, knees right under your hips, and we're going to do a cat and camel. So as Victor's head comes up, his spine concaves and relaxes all the way down. Then he's going to drop his head, tuck his tailbone underneath, firing those lower abs, letting his head hang without any tension on it, and then go back into the first position. So he's going to be concave. Then he's going to be convex. Then he's going to put his back in a neutral position in neither one of those, and he's going to keep his core really tight, and he's going to extend one arm and the opposite leg at the same time, and holding it there, keeping his pelvis level. He's going to come down together, and he's going to switch to the opposite side. This requires a lot of core strength. Please watch your patients very carefully that they hold this great position and down. Progressing our core exercises, Victor's going to go into different pieces of a plank exercise, different positions. He's going to first start down on his elbows. He's going to extend his legs out and go into a plank position, holding his core in really tight, tightening his glutes, tightening his legs. Requires a lot of shoulder and shoulder blade stability, and he's going to be parallel to the floor. Caution to watch your patients so they don't dip their hips down too low or up too high. The next progression of a plank exercise, Victor's going to go up onto his hands. This is called a high plank. In this position, same thing, tight core, good position, holding steady. We're going to hold this for all the way up to a minute or a couple minutes with our patients. And then the side plank. He's going to go down onto his side, onto his elbow, keeping his elbow under his shoulder, and he's going to lift his hips up, bring his hand down, and head back. So he's contracting all of his ab muscles, in particular the ones underneath that he's firing to hold his pelvis and his trunk up against gravity. We progress to more shoulder and shoulder blade exercises and core stability on the ball. So Victor's going to lay down on the ball, and he's going to bring his arms out at 90 degrees of abduction in neutral rotation of his shoulders. While he's holding his trunk nice and tight in his legs, he's going to roll his hands back into full external rotation and then bring them on down. This requires a lot of stability and strengthening of the shoulder blade as you activate the external rotators of the shoulder. And you don't need a lot of weight for this because he's against gravity. So you may start out with your patient with nothing in their hands and then gradually work up to some light weights. Another great exercise to do on the ball is a V-lift, where Victor's going to start with his thumbs pointed toward the ceiling. He's going to lift his arms up toward the ceiling and his chest as he comes up and back down. This requires a lot of shoulder, back extension work, and core stability. So you're going to have your elbows straight now, elbows, thumbs to the ceiling, elbows straight, and lift. For low extremity strengthening, we'll do a series of squats and lunges, but it's really important that you watch the mechanics of how these patients perform these activities. Victor's going to do a really great squat first, look at his mechanics, knees, over feet, hips, and so forth, keeps his trunk nice and upright. He'll go ahead and do what we typically see with patients that we have to be careful and watch for, is as they come down and squat, they let their knees collapse. And their arms and their chest. We don't want to see that happen. So let's go back to the good one. And we want to make sure we strengthen these patients in a really good postural position and really good form. To increase leg strengthening, we want to work on lunges, and we want to work on all three planes. So what Victor's going to do is a forward lunge, and then a side lunge, and then a back lunge. We'll do that again. I like to have patients do this in a mirror so they can watch that their knee's right over their foot, their hip is right over their knee, and their core is really tight to hold their trunk in a good position. And Victor's doing it just great. So if you can mimic this position, it would be wonderful. So forward and side and back. Another progression for lower extremity strengthening is we want to strengthen patients as they walk and as they move, as they're going to do in their sport. So what Victor's going to show next is a walking lunge. Again, watching the mechanics that the knee and hip are right at a 90-degree angle, right over the foot. The trunk is upright and controlled. So Victor's going to do walking lunges. So he's going to take a step, go down, fire both legs, come up, alternate, changing legs. And you'll do as many as you can down one way, and then you're going to come back the other way. He's going to go down, fire both legs, come up, and then switch legs, going down and coming up. Good. To continue to progress our upper extremity strengthening, we're going to use a resistant band to work the muscles around the shoulder blade, and the chest. This is called a dynamic hug, and we're going to add a forward lunge to it. So what Victor's going to do, he's going to lunge forward as he squeezes his chest muscles together in front of him and coming back, alternating feet. He's going to lunge and squeeze at the same time. This requires a lot of core strength because you're unweighting one leg, and you're also moving your arms against a resistance. So a dynamic hug with a forward lunge with a resisted band. Good. Also important when we're working on the manual therapy for these patients after we've mobilized their shoulder and worked on their strength a little bit is to do some dynamic P&F patterns. It's very important for the shoulder and shoulder blade to be strengthened in multi-directional planes of movement. So one of the patterns that we do is we're going to have Victor start with his thumb down across his body. We're going to have him lift up, bring his hand back, rotate around as I resist him all the way through to the end of his shoulder flexion. Then he's going to squeeze my hand, and he's going to come all the way back down to that starting position. So he's going to open his hand and push, and you want to offer just as much resistance as they can handle, and squeeze, and then come on down to make sure you go through the full range of motion. The second pattern we'll need to do with the patient to complete working the whole shoulder and shoulder blade is Victor's going to start with his thumb down. He's going to squeeze my hand, and he's going to lift up, and he's going to come across his body. Then he's going to open his hand and wrist up, and he's going to rotate that thumb back down to the starting position. So he's going to squeeze and come across, pull across, and then he's going to open and rotate that thumb back down to the starting position. You're brilliant.
Brilliant.
Brilliant. These are just a few exercises from our protocol, but the entire protocol will be available online for patients and for medical professionals. Our Center of Excellence rehab protocol will assure great outcomes post-surgical. The patient will look, feel, and function to their maximum potential. The patient will feel good about themselves, about the way they look, about how they feel, and it will enhance their feeling of self-confidence. And it will allow the patient to participate fully in any activity or sports of their choosing. Thank you so much for your interest in our protocol, and everyone here at Evolve is available to you. If you have any questions, please don't hesitate to contact us and allow us to help you with your patients.